So today we're going to be talking about renal Doppler ultrasound. Spend a lot of time talking about renal artery stenosis in particular, but we'll kind of cover the whole spectrum of things in different diagnoses that we can see with renal Doppler. So first thing I just wanted to cover, which is kind of basic renal vascular anatomy. So we'll talk about the renal arteries and veins. So the arteries typically come off just inferior to the SMA, about the level of L1, L2. About 25% of people will have an accessory renal artery. This is really important to consider, especially in the setting of renal artery stenosis. We always want to make sure, whenever possible, that we look for those accessory renal arteries and fully interrogate them whenever they're present. And then they divide sequentially into all these smaller distal branches. Again, we'll talk about momentarily with renal artery stenosis. These can be important, particularly in our pediatric patients. A lot of stenoses can happen more peripherally. These really small vessels can be difficult to interrogate, but just be aware of all these different branches that exist. So our typical renal artery waveforms are typically going to be low resistance. They're going to have a very rapid systolic upstroke. They have this early systolic peak, which is kind of one of the unique features of the renal artery waveforms. Then typically will have forward diastolic flow. The main renal arteries and the more distal arcuate vessels typically have a pretty similar waveform, just with a little bit lower velocities within the arcuate arteries. Other thing to keep in mind is that there are some age-based variation in the kind of shape and appearance of the waveform. So for example, this is a premature infant, so we can see the resistive indices are much higher within this renal artery, close to 0.9. So typically we consider up to 0.9 to be normal in that particular population, whereas in an older patient, we would consider that to be abnormal. But we'll talk about that momentarily as well. But just be aware that these waveforms and resistive indices can vary with age as well. As far as our renal veins, the left renal vein will cross over midline, will come between the aorta and the SMA to get over to the IVC. That can have an impact on the waveforms that we can pick up from there, just because it is in such close proximity to the SMA. Sometimes you can get some of that adjacent pulsatility, will cause a little bit of pulsatility within that waveform. But overall, the veins will typically have forward phasic flow, cardiac and respiratory motion variabilities. This was a really old paper, but this was kind of interesting to look at. So this was a paper that was kind of talking about just the visual assessment of the waveforms that can be effective in the evaluation of renal artery stenosis. But this is kind of a nice look at what happened to the waveform as you move forward with higher degrees of stenosis. So as I mentioned before, kind of this early systolic peak, so very rapid systolic upstroke. You kind of have a little downward deviation and then a forward systolic flow after that. So this is what our normal waveform is going to look like. There's just an example of what this looks like on an actual spectral tracing. About 60% stenosis, you start to lose that early systolic peak. You still have a little bit of a deflection there, and then later on, so over 80% stenosis becomes more of just a rounded waveform like this. So again, just kind of be aware of this early systolic peak. It's just kind of one of the unique features of renal arterial spectral waveforms. Also just wanted to talk briefly about some of the optimization of imaging techniques. This is a very technically detailed examination, so a lot of things for our sonographers to keep in mind as they're going throughout this examination. So as far as color Doppler, we always want to make sure that we're using appropriate transducer for the patient size. So a lot of our smaller pediatric patients will be able to use those higher frequency transducers. Those are going to be more sensitive for slow flow, but they don't have as good of penetration, so not going to be as effective in larger patients. They can also be a little bit more susceptible to aliasing. We always want to keep in mind our power and gain, just making sure that we're setting those to get a good flow signal while minimizing artifact. So again, if our patients are moving around a lot, you might have to tweak those settings just to minimize that aliasing that might happen. As far as our velocity scale, we want to optimize that for the region of interest. So just keep in mind whether you're looking at a artery or vein, just set your velocity appropriately, again, to minimize aliasing while detecting those lower velocities. Then with the color box, you just want to optimize your region of interest to maximize your frame rate and resolution. As far as the spectral Doppler, again, making sure that velocity scale is optimized for the vessel that you're looking at. We always angle correct, and we always want to make sure that we're following appropriate Doppler techniques for these patients. So the angle should be less than 60 degrees, and we always want to use angle correction whenever we're looking at the renal arteries and veins. So just a couple examples. So these were just a volunteer that offered to let us do some bad images. So these were not obtained clinically, but just to kind of show you what happens when you mess with these settings. So this is a patient on color Doppler. So this with an appropriate scale, so you can see the appropriate flow within the renal vasculature with no signs of aliasing. If we turn that color scale way down, you get all of this artifact, all this aliasing that happens. So this can just visually looking at it, if you're not paying attention to that scale, can make you think that there might be elevated velocities within there. Similarly with our spectral Doppler scale, so this is with an appropriate setting, so we can see the peak. We can make our appropriate measurement of the peak systolic velocity. In this patient, our scale is not set appropriately, so we have some aliasing. We're not able to really pick up exactly where that peak systolic velocity is happening. And then similarly with our angle correction, this is kind of showing what happens when we don't do that appropriately. So this is with an appropriate placement of the Doppler angle, so it's going to be parallel to the vessel wall. So we can see in this case it's about 112 centimeters per second. If we set the baseline incorrectly, we're not able to appropriately see where that peak systolic velocity is. This example is when we're not angle correcting. This is, as I mentioned, the same exact patient, the same point in time. So we can see that the peak systolic velocity is about half of what it is. So it's about 66 in this patient as compared to, we know the real velocity is around 112. Then this is when we set the angle incorrectly. So this is when it's more perpendicular to the vessel rather than parallel. And again, you can see how dramatically that changes the velocities that we're getting, about half of what it really should be. I also just wanted to share our protocol for these patients. So again, we always angle correct, try to keep that angle at less than 60 degrees for all of our vessels. We interrogate the full length of the main renal artery, so from the hilum to the aorta. We do spectral waveforms at each of these different locations, so at the hilum, at the mid portion, and at the origin, getting resistive indices from each of those locations. As I mentioned before, we always try to take a look for our accessory renal arteries. If we do see those, we again do that full interrogation along the entire length of it. Similarly with the main renal vein, so we're going to look at the entire length of that, from hilum to the IVC, again, getting spectral waveforms along the entire length of it. Then the arcuate arteries, so this is something we've kind of changed our approach to over time. So we get samples from each of the different portions, so superior, mid, and inferior pole of the kidney. We changed this recently to get 2 different spectral waveforms, so we get 6 total. So as I mentioned before, you have all these small branches that occur peripherally into the distal portion of the kidney. So if you're trying to pick up, kind of indirectly picking up a more proximal stenosis, I think giving you more samples is going to give you a better chance at picking up stenosis in one of those smaller vessels. So we used to just get 1 sample from each of these 3 portions here, but now we try to get 2 in each of those different locations. MFI, we really like using MFI as well to see some of these smaller peripheral branches as well. So just a couple questions just to kick us off for our discussion as far as the appropriate protocol for renal Doppler. So first off, do you guys ask your patient to be NPO for this examination?
We do not. Was that a yes, you do, Judy?
We do, yeah, to try to decrease bowel gas as much as we can. Does it help? Probably not, but that's
Yeah,
what we
we're in
do.
a similar boat. Yeah, we used to. So probably we changed it probably 3 or 4 years ago. We used to have them be NPO for that similar reason that it could potentially decrease bowel gas. We changed it so we don't require them to be NPO anymore. That's kind of controversial with my sonographers. They weren't super happy with me about that, but I think we've, at least anecdotally, I think we've gotten similar quality images as we did before. So we are not currently making these patients be NPO. I don't know what the right answer is for that, but theoretically it could decrease bowel gas and give you a better quality exam, but I haven't personally noticed that. Then there was a question that was submitted. Do you ever perform sedation? So for your younger patients that you're doing a renal Doppler ultrasound, do you ever sedate patients for this? Yeah, we don't either. I wonder, do you ever sedate for any ultrasounds, even outside of renal Doppler?
Not that I can think of.
Yeah, we don't either. I wonder, I don't know if it's more common in the kind of international population. I don't know if other countries are practicing differently here, but at least as far as in our U.S. population, I am not aware of anybody kind of routinely sedating patients. But I mean, this can be really, technically challenging examination. You have a wiggly toddler, but yeah, we're not ever really performing sedation for these patients.
We've been
Then
asked
also,
to
okay.
we've been asked to combine, like, a kid has like an MRI for some reason, and then they come out of sedation and we're asked to do the study immediately following. And I find that is worse because the patient is always coming out of anesthesia and they're like fighting you even more. But we will never actually like purposefully sedate only for the purposes
Right,
of any ultrasound ever.
right, that makes sense. And then wanted to just briefly kind of discuss indication. So this is from the ACR practice parameters document. So I think this is, a reasonable list, talking about renovascular hypertension, which we're going to talk about. A lot of this is more adult oriented. So talking about, abdominal bruits, things like that. One thing I found kind of interesting on here was this one here. So talking about hydronephrosis in children and adolescents. I know there's a little bit of literature on using Doppler parameters to differentiate between obstructive versus non-obstructive hydronephrosis. We're not really routinely doing that. Are you guys ever doing ultrasound or renal Doppler for that indication? Yeah, we're not either. I had kind of honestly forgotten about it before I was looking through this indication list and remember that they have this paper talking about this.
Yeah, in fact, I hope my urologist never see that.
Yeah. And then the other kind of thing is, I think with Doppler exams in general, they're always kind of challenging just from a, time perspective, they're challenging exam to do. Our sonographers always try to minimize when they have to do Doppler. So, and I have some discussion points on this later, but do you guys run into that kind of ordering of unindicated renal Dopplers, and do you kind of go along with it, or what's your kind of approach or advice for handling those kind of studies?
So we
Go
actually,
ahead.
one thing I did when I got to CHLA is just to kind of decrease the numbers of orders for younger children. So like basically 5 years and younger, I just said we're not going to do it. And so far we've had good luck with that. So then that kind of like decreased all of the ones that would have been ordered just randomly for hypertension. And we just do like a renal ultrasound and do look at the renal veins because that's like the most likely pathology that may happen, especially in the NICU babies. But other than that, if they're older, I mean, if it's hypertension or any of the other indications, like it's harder to push back.
All right. Yeah, and I like when I was looking through for cases for this conference, I found, like a renal Doppler for UTI, and we apparently just did it because it showed up on our list. But like stuff like that, I have a harder time with. And the Doppler charges a significant extra cost, and it's time for our patients. It's not easy scans for our patients to go through and for sonographers to perform. So I think trying to optimize and only do these in appropriate patients as much as possible is definitely a worthwhile endeavor.
We see a fair number ordered on the inpatient side for patients who are like post-op having, probably pain-related hypertension. And so I will call the ordering providers on those and let them know that that's not really the intent of this exam. And so it takes a lot of individual phone calls and education, and it's sort of radiologist dependent.
Right. Yeah, and that's such a challenge too, just the time it takes to, reach out to providers and get them on board with it. I think it's one of the more challenging parts of our ultrasound workflow. All right, so this is a case just to kind of kick off our discussion of renal artery stenosis. This is the older patient came in with hypertension. So looking at the right main renal artery here, we can see there's elevated velocity, so up to about 280 centimeters per second. Looking more distally, the waveforms within the arcuate arteries, so pretty reasonable resistive indices. So we had called this potentially concerning for renal artery stenosis. So the patient went on to have a CTA. We can see there's a little accessory artery that's getting cut off on my MIP image here, but main renal artery looks totally wide open and patent, so really didn't correlate with what we were seeing. So kind of ended up being a fake out on our ultrasound here. So with renal artery stenosis in our pediatric population in particular, there's a lot of challenges that we run into. Limited data. So this is what I'm going to focus some time on the next slide, just kind of reviewing the literature and kind of where we're at and what we know about this diagnosis. A lot of age-based variation. So most of the data that exists out there is for the adult population. So probably applicable to adolescents, but as you get into the the neonatal and kind of toddler population, really tough to know what to do with those patients. Pediatric patients more often will have peripheral vascular involvement as compared to the adult population. Typically atherosclerosis, so typically kind of affects the main renal arteries as compared to our pediatric patients. Then just kind of from a technical point of view, just the vessels being smaller just makes them more difficult to interrogate. Again, particularly as we get out to those either accessory vessels or to the more peripheral vessels. So I kind of want to just put together just a little bit of review of the literature that's out there. So this is one of the older papers that I could find, so from the late 90s. So this is one of the first ones I could find talking about evaluation of renal artery stenosis in children. So smaller number of patients, about 22 patients in this study. So they use these two diagnostic criteria, so more than 170 centimeters per second, then a finding of color Doppler aliasing. So using DSA as reference, so both sensitivity and specificity was about 80% for detection of renal artery stenosis. This came out 2013, so this is a little bit larger patient population. So they used a little bit more broad diagnostic criteria, so velocity of 180, acceleration time of greater than 70, then if they saw parvus tardus waveforms. So this one had a little bit lower sensitivity, but higher specificity than that prior study. Next one, so this came out the next year. So this was this used both CTA and MRA as reference, but they had 48 patients total, but only 23 of those had DSA as their gold standard reference. So they did not use peak systolic velocities. So they only used an RI of less than 0.5 or tardus parvus morphology as their kind of diagnostic criteria. So again, diagnostic performance in that population kind of in the mid to low 70s for both sensitivity and specificity. Then this came out in 2017. So this was the largest paper that I'm aware of in this particular population. So they basically are trying to make the argument that DSA is really going to be the gold standard than the non-invasive imaging. So they use that as kind of a catch-all for both ultrasound as well as CTA and MRA. They use much broader diagnostic criteria than those other papers. So either direct visualization, the parvus tardus, the 200 centimeters per second for the peak systolic velocity, acceleration time, and then they use this renal artery aortic flow velocity ratio, which is more often used in the adult population. They use this difference in the resistive indices of more than 0.05. Then they considered a size discrepancy of greater than a centimeter as a potential indirect sign. So using any one of these criteria, so again, pretty low sensitivity, so about 63% of a higher specificity. Then if they included that criteria of the difference in the kidney length, a little bit higher sensitivity, but lower specificity. There's also not a whole lot of data out there for CTA and MRA, but in this particular paper, they talked about CTA about 88% and MRA was 80%. So basically their conclusion was that DSA is really going to be the gold standard. So if you have a high clinical suspicion for renovascular hypertension, both ultrasound or all three of CTA, MRA, and ultrasound can all miss treatable causes of renal artery stenosis. Then this same year, so this was a nice review paper from our friends at Cincinnati. So they kind of reviewed the literature. This wasn't a retrospective or novel new patient population, but kind of just summarizing kind of most of the literature that I just talked about as well. So their conclusion of this paper was that renal Doppler ultrasound can add a lot of value to the evaluation of patients. And that's an appropriate initial test. Kind of the reasoning for that, we just talked about in that last paper that, it's not going to be the gold standard for diagnosis, but it can still provide at least some guidance for additional workup. So for example, if you see abnormal vascular waveforms within both arteries and the aorta, that's going to direct your evaluation more toward the aortic cause as compared to a renal cause of the hypertension. They also talk about can evaluate the actual renal parenchyma itself, see if there's scarring, see if there's any kind of renal mass or any other kind of abnormality as well. But they really did kind of go on to the same conclusion that overall you can't really stop if you have a high suspicion for renal Doppler ultrasound. If it's positive, you're almost always going to need additional imaging. And then if it's negative, you're also going to need additional imaging. So at the end of the day, they kind of concluded it's probably a pretty good screening test. But if you have a high suspicion, regardless of whether the ultrasound is positive or negative, those patients are probably going to need further angiography to further evaluate what's going on. So this is how we report these, and I'll get your opinion on how you guys approach this topic as well. But this is kind of our reporting template. So as I described in some of our prior conferences, we have everything is linked to our, through modeling to our ultrasound machines. So everything, all these red boxes here, these automatically get populated. So we don't have to do anything manually here. So we report all of the peak systolic velocities at each of the 3 locations within the main renal artery. And then we get our arcuate artery, we get those 2 different samples for the resistive indices. Then we include a little reference kind of in the text of the findings as well. Then these are our 2 impression fields that we can pick from. So if we have any of these findings are abnormal, or if they're normal, then we just say, normal, but we say if there's a moderate or high suspicion, then they still need to get further imaging. And if it's low suspicion, then you can probably stop there. Then if it's abnormal, we don't directly call it renal artery stenosis. We just call it an abnormal renal ultrasound. Then again, we recommend further imaging with CTA, MRA, or DSA. I just wanted to share this so if anybody finds it helpful. This is from the Society of Pediatric Radiology. The Ultrasound Committee had put this together a few years ago. So this is just a reporting worksheet. We actually don't use this, so we don't use any reporting worksheet for renal artery or renal Doppler ultrasounds, but I just wanted to share this in case anybody finds it helpful. But they did include on here, this is the kind of references they included, so these different ratios, the RI, and then the peak systolic velocities. All right. So as far as our kind of discussion questions for this topic, so I'm curious for you guys. So as far as at my institutions, the only two things we look at are the peak systolic velocity within the main renal arteries, and then we look at the resistive indices within the arcuate artery. So we're not looking at any of the ratios or some of those other kind of diagnostic criteria that I had mentioned. But I'm curious what your general approach to how you report these, kind of what numbers you routinely report, and kind of what your diagnostic cutoffs are for what you consider to be abnormal.
Well, I would say I don't use any main renal artery pure number, that 180 centimeters per second that you mentioned. I think it's really important to have the aortic velocity at the level of the renal artery ostia so that you know where the point of flow acceleration is. And I don't know what to do with that 180. I mean, if you have like proximal, mid, and distal renal artery and it goes from like 179 to 180 to 181, are you going to call that a stenosis? No. I mean, you need to know like what it is in the aorta, because is that 180 three times the aorta or is it the same as the aorta? So I don't like just the pure peak systolic velocity in the main renal artery because I think we're not able to see the big picture. And, as you mentioned, these are pediatric patients, so most of them are not going to have ostial renal artery stenoses, and that's really what the renal Doppler exam is designed to detect, or adults with atherosclerotic disease in the aorta that's affecting the renal artery ostia. So maybe that's not that important, but we do see kids with mid-aortic syndrome or fibromuscular dysplasia, NF1, those sorts of things. So I still think just looking at the main renal artery you're gonna potentially overcall some things that are normal or potentially miss some things that are abnormal.
Yeah, I have, we kind of settled on that just based on the literature. Like I said, on the adult side, there's a lot more robust evaluation of those ratios. And I think, in the pediatric patient population, it's exactly what you're saying, their age-based variation. It seems to make more sense to use the ratios just to have some of that kind of control for their hemodynamics. But I wish that some of those papers that had been written had looked at, those ratios and not just some of the broader criteria that I had mentioned, the absolute velocity and the RIs alone. I think it would have been valuable to look at that as well. And I'd be curious to see a study that looked at that in more detail, because I think, to me, at least logically, it makes sense that those ratios would be more helpful than just looking at the pure velocities.
Yeah, I think the ratio ought to be helpful wherever you apply it. I mean, like it's really the ratio is just looking at flow acceleration. You're going from a normal flow state to a jet. So, it shouldn't have to be between the aorta and the proximal renal artery. It could be between the proximal and the mid, or the mid and the distal. But really, you're just trying to catch the point of flow acceleration as the indicator that there is a flow limiting stenosis there.
Right. That makes sense. And then, so next question, I'm kind of curious just kind of what the overall kind of workflow at your institutions are as far as, the big picture of evaluating patients that have, clinical suspicion of renal artery stenosis. Where does kind of ultrasound fit in that for you? And then how do you see the role of CTA or MRA, and then, catheter angiography?
Yeah, I'm curious to hear from the others too, because I'm not particularly happy with the way it's done at my institution right now, which is that, you know, any pediatrician, any nephrologist, any ER doctor, any, inpatient PA seems to start with renal artery Doppler without really thinking through, do they even have what appears to be renovascular hypertension, or do they have some other obvious cause for hypertension? So I feel like our N is so large that the number of like true positive exams that we see is so small because we're imaging all these kids who probably don't need it. Our interventional radiologist will absolutely do a CTA before every patient that they're going to see for potential treatment. So, um, I don't know. Sometimes I think we're doing way too many ultrasounds and not enough CTAs.
Yeah, no, I totally agree. And it's interesting. That was the other kind of piece of those different papers that I just shared. That, they all use GSA as the kind of reference standard, but there's a huge number of patients that we really don't know we don't have most of our patients, like you're saying, they stop at the ultrasound. They don't get an additional imaging. So we don't have a true, gold standard for whether they really had any kind of renal vascular abnormality or not. So I think those papers are kind of skewed in that way, and that their patient population that they have a gold standard for is probably patients that had a higher clinical suspicion that they went on to get that DSA. So it's not really reflective of the true population of patients that we're mostly doing ultrasounds on.
What are your thoughts on, like, I know we don't really have great decision support software yet in radiology, but what do you think about limiting who can order these studies, like to nephrology, maybe not even urology, but like I feel like nephrology, they have to have a high enough pretest probability in order to get these studies, right? Like if they're not going to go on to do something else after, regardless what the result is, I feel like we shouldn't be doing the ultrasound in the first place. Amy, we have the same situation as you. We have this post-op kid in pain, in like post-op pain in the PICU, and the first thing they do is get an ultrasound with Doppler because it's easy, and we go do it because it's, oftentimes it's a lot easier to just do the study rather than call them up and question them and potentially offend somebody who is like, why are you questioning my order? I'm the doctor. You know what I mean? So I don't know. What are your thoughts on limiting it to just nephrology being able to order these? Or who do you think would be the best like physician subset to limit these to?
Yeah, maybe like nephrology and cardiology, and then with like a lot of targeted education from us first to make sure that they also are kind of applying consistent criteria to who they're referring. I mean, we get them from the emergency room at like 3 in the morning. And I just, no one's doing their best ultrasound at 3 in the morning, and no one's interpreting their best Doppler ultrasound at I just made a new word. Um,
That's what you would be dictating 3 in the morning, though.
Manifesting what that was like. I mean, um, Jeffrey, you mentioned like the importance of finding accessory renal arteries. We're probably not finding those at 3 in the morning. We're not finding them a lot of the times on a day shift because those are hard, but I don't know. I think it would be nice to have them limited to specific hours and specific ordering groups with a lot
Yeah.
of, education and sort of agreement between radiology and the ordering physicians as to which patients qualify.
I guess that's kind of like my point. Like these aren't emergency studies, right? Like I forget at what point in my training, one of my attendings told me like renal artery Doppler is for patients who are refractory to medical therapy. So like they have to have tried several antihypertensive, maybe get some labs that are helpful first before they go on to renal artery Doppler, which I don't think that's actually happening these days. So
Mm-mm.
I don't know. Maybe we should come up with some sort of a consensus statement. Jeffrey at SRU proposed that as the next SRU consensus statement. Like this and this needs to happen before the ultrasound with Doppler is allowed. Okay, I'll get off my soapbox. Thank you.
Yeah. Yeah. I mean, I think, to me that in a theoretical world, I think, it makes 100% total sense. We've tried to do that with some other things, and in practice, I think the ordering providers just are very unhappy with like being restricted. Like we have, like for cryptorchidism for like testicular ultrasounds, we like the American Urologic Association, they came out with their formal guidelines saying ultrasound should not be done. They should just be referred to urology. And we still get, orders from pediatricians and other people. And whenever we call them and try to cancel it and say, just send them to urology, don't order this ultrasound, there's always pushback on it. And then kind of same thing with volvulus ultrasounds. Like we had a period of time where we tried to require a pediatric surgery consult when they order those ultrasounds. Like we didn't let them just order them however they wanted. And they basically about half the time they just completely ignored that and they just ordered it anyways. And so I think it makes perfect sense, but I think it's, at least in our practice environment, I think it seems really challenging to actually implement those restrictions on people. So I don't know. It's always worth a shot, but it's hard. Okay, and the next question was in your reports, do you actually ever, if you have a negative renal Doppler, do you ever recommend additional imaging if you have, if they have a really high, specific clinical scenario, they're high suspicion. I kind of showed in ours, like we have that kind of those two caveats if there's low or high clinical suspicion, but I'm curious if you guys ever specifically recommend additional imaging, even if the Doppler's negative.
I mean, I like your caveats, but I just kind of go into it assuming they had a high degree of suspicion if they're ordering a test. I mean, if they had a low degree of suspicion, then like, why did they do the renal Doppler? But so I recommend CTA on everybody. I'm sure people, when they see that I read the renal Doppler, they're probably like, oh, dang it. Amy's not going to allow us to get away with the renal Doppler on this one.
That's funny because I never recommend it. Like I'm just like, if they have, if the situation is right, they know that they have to go on to, we do CTA here, always, not MR. Actually, I think we've done a few MR, but anyway, I don't know. I think as long as you're consistent with, and like these people are doctors, like they should know what to do with what we say. I would hope.
Yeah, you would hope.
Yeah, I'm in the same camp of not recommending, oh, I mean, in general, like not recommending too much afterwards. And also in hopes that they're doctors and they know what they're doing.
Sure.
But what was interesting is that, like as AI evolves and like, with the decision making type softwares, I wonder if eventually you can establish like these are the indications, and then when they're not indicated, or even with the indications, like have it linked to financial stuff, like this is how much the test is going to cost your patient. And I wonder if that psychologically will change practice at all. If any of the clinicians are like a little bit more hesitant if they actually see the cost of all these things, of all
Yeah.
these tests that they're ordering,
Okay.
especially when it says not indicated.
Right. Yeah, that's a great point. All right. So I just wanted to share just a positive case to kind of close out our renal artery stenosis discussion. So this the younger patient is a 3-month-old, came with elevated blood pressure. So the right renal artery, so very elevated velocity, so a little bit over 180. The left renal artery looked normal, that typical systolic upstroke. Overall, kind of more of a disorganized waveform pattern on the right side. More distally, velocities were much lower. So at the hilum, about 26 with more of a tardus parvus waveform. This patient was just kind of observed and then later on developed much higher velocities, so up to the kind of low 400s. Again, these kind of tardus parvus velocities. They also developed this asymmetry. I know these numbers are really small, but had developed a renal size discrepancy. So the right kidney was getting more atrophic. Then on CTA, you can see this tight stenosis within the main renal artery. And then you can kind of see this differential perfusion. So just wanted to share kind of more of a typical positive case of renal artery stenosis. So next topic I wanted to discuss was Nutcracker Syndrome. So I know Erica had already covered this topic a couple months ago, so I won't belabor this too much. So I just wanted to include this for completeness sake. But for Nutcracker Syndrome or Nutcracker morphology, so a couple different things that we look at. So we measure the SMA, so at the kind of or at the renal vein at the tightest point, kind of right behind the SMA, then the more lateral portion of it. So we measure the velocities at both of those locations. Then we measure the actual diameter of the vessel at those two spots. So this particular patient, so it was about 127 at the tightest spot. I didn't include the image, but it was kind of in the low 20s, kind of in the more peripheral portion of the renal vein. So that's what we've kind of decided to use as our diagnostic criteria for this. So we use a peak systolic velocity greater than 93 at this kind of aortomesenteric segment. Then if we use that ratio between the more peripheral segment and that aortomesenteric segment, so if that's more than 4.7, then we consider that to be positive as well. So kind of just demonstrating these two, so on grayscale, so we can see that narrowing. This decreased angle of the SMA aorta, so this has not really been well validated in the pediatric population. So we've talked about this with other things like SMA syndrome. The SMA angle and the overall kind of aortomesenteric distance tend to be lower in a lot of our pediatric patients. Some adult literature also talks about the compression ratio, so the diameter of the compressed to uncompressed vein. But again, not really a whole lot of literature in the pediatric patients about that. Then we talked about our diagnostic criteria for this. So again, I won't belabor this too much. I have a lot of other things I wanted to chat about, but just wanted to briefly review that as well. So next thing I wanted to talk about was renal vein and renal artery thrombosis. So this is a younger patient, so a premature infant. They came in with a palpable abdominal mass. They had recently had a UVC removed as well. So we can see in our grayscale image, so this is the main right renal vein. So we can see that the walls of the vessel are echogenic, and we can see some of this intraluminal thrombus as well. On color Doppler imaging, we can see that it's not really filling in very well with color. So overall consistent with renal vein thrombosis. So in spectral imaging, so we can see a normal left renal spectral waveform. So we can see our normal velocities here. We can see our normal parenchymal echogenicity. If we compare that to the abnormal right kidney, so it's very large, so it's about a little bit more than 1.5 centimeters larger than the left kidney. Overall, just kind of edematous in appearance with loss of corticomedullary differentiation. Then looking at the waveforms, you can also appreciate that there's reversal diastolic flow within the main renal artery in this patient. This was later on, so this is about 3 months later. So the right kidney has developed progressive atrophy. So again, just kind of a typical case of a neonatal renal vein thrombosis. So just a kind of brief overview of this. So risk factors in our neonatal population, so it's going to be dehydration, so patients that have either blood loss or sepsis, things like that. Maternal diabetes is also a risk factor. Older patients, again, any patients that risk for kind of coagulopathy, trauma, dehydration, all those types of things. Typically, these patients will present with either flank pain, nephromegaly, like in our case with this palpable abdominal mass, and then hematuria or proteinuria as well. As far as our imaging findings, like in this case, we're going to see an enlarged hyperechoic kidney with that absent corticomedullary differentiation. We did see this in our case, but you're not always going to directly visualize that intraluminal thrombus. Particularly in our neonatal patients, sometimes the more of the intrarenal branch vessels are going to be the ones that thrombose, so you're not necessarily going to directly visualize that like you would in a main renal vein thrombosis. Like in our case as well, once you have chronic thrombosis, you start to get renal atrophy. You get that increased echogenicity of the renal parenchyma. And sometimes you can see the calcified thrombus as well. With Doppler imaging, we're going to see the decreased or absent venous flow. And then within the arteries, you're going to see those higher resistance waveforms. And then you can get diastolic flow reversal like we saw in our case as well. Then kind of flip side of that, I just wanted to share a case of renal artery thrombosis. So this is a patient, again, a younger patient at ALL, came in with abdominal pain and distension. So on color Doppler imaging, we can see that there are several defects within the perfusion of the kidney. So we can see kind of in the upper pole here and then at the lower pole as well, kind of these wedge-shaped areas of absent perfusion. Patient went on to have a CT. So again, on both kidneys, you can see those areas of absent perfusion. So these kind of segmental infarcts of both kidneys. So renal artery thrombosis, so this is often in our neonatal population, it's going to be associated with a indwelling umbilical arterial catheter, or otherwise patients that have a hypercoagulable state. Patients will typically present with either hematuria, hypertension, impaired renal function. Grayscale imaging, so like always with our vascular thromboses, you can see the thrombosis within the vessel lumen. The parenchyma is going to get enlarged and echogenic. And then segmental infarcts, like in our case, they can be either hypo or hyperechoic, kind of depending on where they are in the phase or how kind of acute it is. And then with Doppler imaging, we'll either see absent flow, both in the arteries and the vein, as well as absent parenchymal flow. And then a segmental occlusion, you'll kind of see these wedge-shaped areas of decreased perfusion. And I kind of want to use this as a jumping off point for kind of another discussion point. So this is a 5-day-old, so we were asked to evaluate for renal vein thrombosis. So in this particular case, we only did color Doppler imaging, so we didn't do any spectral analysis. So we just did these kind of color images of both the renal arteries and renal veins on each side. But I'm kind of curious what's your general approach to if there's clinical suspicion for either renal artery or renal vein thrombosis. We've talked about, we can include color Doppler imaging as part of our typical kind of renal ultrasound protocol without having to do an additional charge. But once we add the spectral Doppler, then we have to do a more thorough evaluation. I'm kind of just curious what's your opinion on when you can get away with just doing color Doppler alone versus when you would add spectral Doppler as well.
So it's probably us underbilling, but we would just do the color and then just place one spectral, because we do add the spectral for portal veins for our normal abdominal ultrasound. So we don't necessarily, have to bill for the spectral. So kind of like
Yeah, we
cheating.
also, oh, it's not cheating. I mean, cheating would be like if you billed for it and you didn't do it. You're doing the opposite. You're underbilling, but
I
you're like Robin Hooding it. So we'll do like a limited Doppler in that situation where I do think it's still helpful to at least get the arterial spectral, because if there is like branch venous thrombosis, you can
Yeah,
still
exactly.
pick up the abnormal diastolic flow, even though the color may look normal. So I think in that population, looking for renal vein thrombosis, it's still good to put spectral on the artery.
Yeah,
But
I totally agree. And yeah, we run into the same thing like you mentioned, had to with the portal vein. Whenever they put the indication of portal vein thrombosis, our sonographers always ask if they can just put color on it or if they really need to do a full kind of spectral analysis. And at least our billing people are pretty picky about even if you do one single spectral waveform, we have to have a Doppler charge for it, so they don't let us get away with that, unfortunately. Um, but yeah, and in like cases like these, when they just say, evaluate for renal vein thrombosis, I think there is nuance to it. Just putting color on the main renal vein, I agree. I don't think is necessarily adequate to, especially for those smaller kind of intrarenal branch vessels. I totally agree. Looking at the spectral waveforms in the arteries is helpful in those cases. So I usually err more on the side of doing spectral Doppler in those cases, but like we've been talking about, it's always the balance of time and cost and diagnostic yield for those type of things. But
yeah, like
We
I don't think in that population you don't need like a full Doppler. You don't have to look at arcuates. You don't
yeah,
need to
yeah,
multiple points in the renal artery. You just need like a little window into what's going on with that arterial waveform.
right, yeah, makes sense.
we've run into issues in the past where we have like shortened protocols or examinations or cut certain things out based on the indication that's provided, but like we don't always have the complete clinical picture, and so there'll be something else going on. I don't want to miss something by us like cutting down stuff. Now we will definitely not, we won't we won't go crazy with Doppler if it's like, concern for renal vein thrombosis or whatever, but we will, if they order a Doppler, we will still do a Doppler. We just might do an abbreviated protocol.
Right, that makes sense.
actually, since we're talking about renal arteries, thrombosis, have you all tried using ultrasound or been asked to use ultrasound to kind of differentiate between pyelonephritis? You know how like on CTs when there's like wedge shape, hypo intense or hypo intense structures and the differentials like pyelo or infarcts. Um, would you have you ever been asked to use ultrasound to differentiate? And I'm guessing you would be able to differentiate because then when you put Doppler on it, there's like no abnormalities if there's no thrombus. But what if the thrombus is smaller or, things that you wouldn't be able to detect? And especially if CT, you don't see the thrombus, then what are the chances of it showing up on ultrasound? And the reason I asked is I recently was asked to do that. And I was just like, my guess is going to be as good as the CT, but clinically, I knew it was going to be pyelo because the kid had like a positive UTI, like based off of labs and a fever. So like all signs pointed to like pyelonephritis.
And yet you say that these are doctors that should be knowing what to do with.
But little radiologist me was like, oh, maybe clinically I'm missing something because everything seems to fit too perfectly.
I've never been asked to do that, but I guess you could just put power Doppler over the kidney and make sure that it's perfusing. I mean, I guess the question is really just yes or no perfusion, right? Because I mean, if it's pyelo, it could be hyper or maybe a little hypo, but it should still have some perfusion.
Yeah, I think that's a good use for like the microvascular imaging techniques, like the
Yeah,
B-Flow and the SMI or whatever your vendor of choice is using. Like I think that can show you like parenchymal hypoperfusion, if you will, even though it's not a perfusion study. But we have when I first came to this institution, our techs would put color on and only show me the hilar vessels. And like every study now, we're trying to get beautiful flow of all the parenchyma when we can. Obviously, sometimes it's technically not possible, but we can see pyelo pretty well that way. And I feel like with an infarct, you're going to have more of a geographic like it's like not enhancing or no blood vessels that you see in that area. So I think it can be helpful, but hopefully you would be able to also see that on a CT. I don't know.
Do you do like a single image, like a single kind of longitudinal image, or do you try
It
to like,
depends. It depends what the text can get. So yeah, there in the protocol it says like one image showing perfusion with either color, power, or we have B flow because we only have GE at this institution. So or beef and or B flow, however you can show best. But sometimes they'll add on a cine if they're like trying to like, ooh, look at how pretty this is. Like, look at all these vessels, or they'll or the opposite, like I can't get good fill in no matter what I do because this kid is crying, sort of a thing.
Yeah, and I wonder, I have a slide coming up, we can chat about it more, but I wonder if contrast would also be an interesting thing to consider in that scenario. Like if you really
Oh
need,
my God, Jeffrey, I love you so much. Thank you.
I almost spoil it, but I have a picture of almost that exact scenario coming up. So I wanted to spend a few minutes talking about a couple transplant cases as well. So this is a patient that undergone a renal transplant that came in with hyperkalemia, metabolic acidosis, oliguria. So it's about 5 days post-op. They had this edematous appearing kidney, kind of this decreased corticomedullary differentiation. On Doppler imaging, so they had elevated resistive indices. So this was kind of more peripherally and then within the main renal artery as well. So we can see these resistive indices are kind of in the mid eights, kind of an abnormal waveform here. Overall kind of decreased diastolic flow as well. So this was I don't think make this diagnosis too often on ultrasound, but this is the case of acute tubular necrosis. So this really is from kind of early dysfunction from ischemia during the actual transplant or hypoperfusion event. So they'll get delayed graft function, elevated creatinine. So oftentimes the grayscale imaging is going to be normal, but they can also get this kind of edematous echogenic appearance of the kidney. There's some overlap in the Doppler imaging with, like we just talked about, with renal vein thrombosis. So they can have increased RIs and then either decreased or reversal of diastolic flow. So when you're kind of considering this diagnosis, it's always very important to really closely look at that renal vein to make sure whether there's flow in there or not. Then just another kind of typical appearance of our post-transplant appearance of the kidney. So again, this is a little bit of an older patient. This was immediately post-op. So very elevated velocities at the origin of the main renal artery, so about 400 centimeters per second. Then at the anastomosis, similarly very elevated. Later on, this patient came in for their follow-up, so normalization of those waveforms. So kind of this typical kind of post-operative spasm that we very typically see with both renal transplants and hepatic transplants as well. So just kind of wanted to go over how you guys approach renal transplants in general. So we're not quite as structured in our reporting of renal artery transplants as we are with renal artery stenosis. We report similar numbers, so we report the velocities as well as the RIs at kind of each of these locations, and then so all gets automatically auto-populated into our report, so we don't have to think of too much about manually putting each of those numbers in there. This is the renal transplant version of that same kind of SPR transplant worksheet that I showed you previously. So as I mentioned, so we don't personally use these worksheets, but if anybody finds them helpful, just wanted to share that as well. So I wanted to, this is the case I was just showing you about the use of transplant or use of contrast ultrasound when transplant patients. So this is a patient that had contrast kind of showing these kind of segmental infarcts. So very difficult, I think, to see on grayscale, but after they get contrast, you can see all these kind of decreased areas of perfusion within the transplant kidney. So I wanted to tie that into a couple different discussion questions here. So kind of same discussion we had around renal artery stenosis is kind of what values do you typically report, and then kind of what are your kind of main things you're thinking about as far as, what cutoffs you're using for either, calling a stenosis or overall just kind of what are you reporting when you're reporting a renal transplant?
I don't use the actual worksheet, or at least our sonographers do not, but I do use the values that are provided in the SPR worksheet.
Yeah, and that was one of the other things that I didn't specifically mention this, but this is one of the transplant specific ratios that they talk about is the ratio between the main renal artery and the iliac artery. We don't personally use this, but this is something that has been described in the adult literature as well. But these are the main things that they included in the worksheet is that 200 for the peak systolic velocity, and then abnormal RIs being either below 0.5 or above 0.8, and then that ratio being greater than 1.8. But we typically focus more on the RIs and the peak systolic velocity and not as much the ratio.
I think these are generally more straightforward to
Yeah.
think about because these have an anastomosis and, a surgical anastomosis. And so they are likely to have the like osteal type stenosis that we're used to looking for in adults. So to me, like this is a great application of renal Doppler transplants because, our exam is designed to detect a stenosis where they're likely to have a stenosis, you know, in contradistinction to the average pediatric patient with native kidneys, where it could be branch or accessory or whatever. But
Yeah, I definitely agree that they're generally more straightforward. And, we typically have, all these post-op exams that get done serially. So patients kind of become their own internal control. We kind of compare what's going on over time, which definitely a benefit as compared to the renal artery stenosis. You just have that single snapshot and try to figure out what to do with it.
mm,
And then as far as the contrast, I know we just briefly discussed that. Are you guys routinely using, I guess not just in transplant, but renal transplants or other kind of problem-solving scenarios for kind of renal pathology? We're not using it a whole lot for kidney stuff, but I'm curious if you guys are routinely using it for kidneys.
we haven't, but I want to hear from Judy.
Yeah, I was gonna say, so our transplant surgeons don't love giving contrast to their transplant kidneys, but this is the one time that like they're like, yeah, cool, do it. Like, but it's only for problem solving. We definitely don't routinely do contrast and ultrasound. And it's super important to remember that there's no renal excretion. So if you're like, oh, is this a calyceal? Was this a fornicel rupture? Like you can't see that with contrast and ultrasound. So then you have to go to an iodinated or GAD based contrast agent. But for vascular assessment, like, heck yeah, if you need to, go ahead.
All right. And then so the last couple of cases, I just wanted to kind of share some kind of systemic manifestations of abnormal hemodynamics that kind of show up in the kidneys. So this is one that kind of confuses our newer sonographers that, if you're not used to seeing this, can kind of throw you off as far as what you're looking at. So patients that have a patent ductus arteriosus, they can have this very unusual waveform within the renal arteries. So they have this very sharp systolic upstroke, and then they have this reversal of diastolic flow. This is one of those ones you'll see it just kind of throughout the renal vasculature. So just kind of being aware that this is something when you see this, this kind of typical waveform pathology is typically going to be younger patients. And typically they'll know the patient has a PDA, but something we can tell them if they're not already aware of it. And then the flip side of that, so this is a patient that had an aortic coarctation. So when you see this diffusely abnormal waveform, so we can see this kind of decreased velocities in these tardus parvus waveforms throughout the aorta, as well as both the main left and right renal arteries. So whenever you see this kind of diffusely kind of symmetric and abnormal waveforms, always going to be an indicator there's something more proximal going on. So in this patient, sorry, my arrow got a little thrown off there, but going to be a more proximal stenosis. So in this case, an aortic coarctation. And last case, so this is just a kind of an interesting one to look at. So this is a patient that had an LVAD. So patients that have LVADs, or sometimes patients that have oscillators, can sometimes get very unusual waveforms. So really, it's going to limit our evaluation of the actual kind of spectral Doppler. But generally, we can still look for thrombosis, seeing if things are patent or not. But doing an actual waveform analysis is going to be much more limited in these particular patients.